right in the center of the frame.
That's
I just did it.
That's what I said over here. Yeah, I should
Move it out a wee bit.
Still good, kind of, it's just a.
My escape.
Oh, that's
So that's
interesting.
Become a star, man. Asking you good questions.
So true, true.
Inspiration, yeah.
Oh, no, there's no issue, except you, if you sit there, someone will be right
Right in the middle of the frame, but that's okay.
You handle it better than most. Gonna make you all join into the frame, huh? Who's good at adjusting these? What should it be?
There's no good place for. We did tonight.
Now you guys don't have to be in the.
It's like around that.
When the discussion comes though, let's put
Yeah.
it on the room,
Yeah.
because last week when I was watching from home, I was wondering who was in the room.
Good.
Taryn, do you want to stand here?
Yeah, I'll introduce you. Kia ora, everyone. Thanks for coming along to listen to Janine talk. I will introduce Janine, even though everybody knows her. Janine has been at the centre for 5, 6, 7 years now. She was also at the hospice, but you've now left that position and concentrating more on your PhD. Yep. Today, Janine is going to talk about the moral distress faced by parents when making a difficult decision for their child. And when we discussed it before, she said something that really sort of brought it home for me, and it was the distress parents face between treating the child that they have now, the very unwell child, versus choosing a treatment for a child in the future who might benefit, or who may be cured. So there's that juxtaposition of now versus the future and the moral distress for parents and of health professionals looking on. So that's today's talk. We will finish at 10:02 for multiple reasons, but one being that I have a sick child at home again, so I have to get away. But Janine, you will be around and you've got your email address available, maybe be on the website, so that anyone can contact you at any time if they feel they need to. Great, thank you. Thanks, Janine.
Thank you.
Thanks, Charlie.
Okay. So this is a topic that proceeded out of my work, and I've been actually had been waiting many years to present it. And in some ways it was quite therapeutic for me to write this, because it was something that it took about 10 years to deconstruct what it was that I had moral distress about, and what I thought about informed consent for innovative treatments that detract from quality of life of those children who are got life-threatening and life-limiting illnesses. So anyway, is this not moving forward? There we go. So I'm going to be using a couple different approaches, but the whole thing is the stories. I love the stories. I think that facts without stories and stories without facts neither are satisfying, but when you put the two together, that they are. One important thing is that this is my version of these stories, and of course, and but I am keeping confidentiality. There's no identifying information of the families that I was working with. A lot of the stories that I chose from this are secondhand narratives. I'm going to describe some nurse practitioners who came to me with their concerns and that I worried about. And so the moral distress, actually, I would say a little less the parents, more the caregivers, including my own, the care providers. Is my slide not?
Right down the bottom, Jean, on the left. Left, your left.
Yeah, but I don't see
And now if you click on there, they should pop up. There we are.
there we are. Thank you. Okay. So the outline of this whole set of stories is that I was the physician director of palliative care services at a really large children's hospital. And early in my tenure there, I was the first one, so it was a new palliative care service, but that the hospital got this huge donation from a private corporation, and the private corporation wanted them to become one of the top children's hospitals and to get really involved with curing diseases that affect children, which of course is a really noble and idealistic goal. But in making a transition from being sort of a regional hospital taking care of kids to being one that's gonna, change the world, there were some snags, and that's what we're going to talk about. So 3 clinical dilemmas from my point of view. And then I'm going to talk about this, but I'll look at them from some different ethical lenses, from frameworks. So talking about research and looking at curative treatment. So this is my summary of the Nuremberg Code of looking at what makes ethical research. So you want voluntary consent, that the results have to be something at least reasonably fruitful to put people through something experimental. You want to use animals first. You want to avoid suffering. You don't want permanent injury. The degree of risk matters to the importance of the problem. You have proper preparation with qualified researchers. Individuals can stop, and research stops if your harms were initially underestimated. So that should be pretty familiar with all of you, but I still find it useful to look at, when you get into the specifics of these things, when you get really into the weeds, when are we actually following these, and when are these looking dubious? The 4 ethical approaches I'm going to use for my stories are principle-based ethics, virtue-based ethics, and feminist, which I find that feminist can be described in a number of different ways. So I'm using these, 7 words? Interdependence, community, connection, sharing, emotion, trust, and process as my take on feminist ethics. Okay, so the first story. So the background, I'm going to tell you about a parental refusal of getting information about bone marrow transplant, and the parent's statement of, I can't listen to what could happen, I don't have a choice. The background is that this is an innovative treatment, bone marrow transplant. Usually we're talking about the setting of multiple relapsed leukemia or multiple relapsed other kinds of cancers. And the chances of these urgent bone marrow transplants go way down of working, and of also of having something called graft versus host disease, which is where the bone marrow attacks the host, the person. So these parents are facing 100% chance of death without the treatment, probably about a 95% of chance death with the treatment. The urgency makes that pretty bad because you can't shop around for the perfect donor because you don't have time. And not only that, but if they survive, we saw a number of sudden deaths that occurred years afterwards, 5-10 years afterwards, because of all of the damage that would be done in this process. Okay, so the nurse practice. So I'm going around and introducing the new palliative care medicine, palliative medicine service to some nurses. I go to the bone marrow unit, and they tell me about their dilemma, which is that they're assigned to give the informed consent for these bone marrow transplants. Some of them are being done under research protocols. In fact, most of them are because they want to look at what's being done. And these nurse practitioners' other role is to provide longitudinal care and support. And their boss is the bone marrow transplant oncologist. And they are in front of these parents who are stressed, who are tearful, they're angry that they're facing these situations. And they say to the nurse practitioner, don't tell me what could happen. If I don't choose this path, my child will die. I don't want to know what the complications are of bone marrow transplant. So go to the next slide. Where'd the cursor go? There. So their moral distress, and I'd go so far to say moral injury, that this was something that's a longitudinal problem, is that they're assigned a role that they can't fulfill. They're supposed to be telling these parents what could happen and to get an informed consent, and the parents say nope. And then they follow these children in the treatment journey, and they often witness both child and parental suffering when they go through this enormous process. And both the process itself of bone marrow transplant is pretty devastating to the system. But also, if you get that graft versus host disease, it's one of the most excruciating suffering that there is. These children have to be sedated for a long time, and it's pretty awful. Won't describe any more than that. And so then they also then see the back end, these nurse practitioners. Well, I didn't know this could happen. How come I didn't know it could happen? If I'd known that my child would be like this with, their skin sloughing off and all these other horrible things, I never would have chosen this. And why did I do this? And so they're seeing it on both ends, these same parents saying, why did I choose this pathway? Now their bosses, these nurse practitioners' bosses, the clinical doctors, they have a couple, they're clinically involved, yes, but they also have some other pulls, which is that they're getting the funding for the research protocols, they need subjects for their research protocols, and the people who go into this field tend to have when that 5% happens, and to get to own that this child is alive because we got them a bone marrow transplant and saved them. I think that these doctors go into it, they have that personality type where they look at that 5% like, wow. And with me, I was treating a lot of that 95% who didn't do so well and looking at the suffering that they went through. So there's a sort of, little bit of a disconnect or a difference of point of view. So my main impressions of the issues in this story, the first was informed consent. That what do you do when the people who are making the decisions, particularly when they're making it for somebody else, that they're surrogate decision makers, they're not making it for their own body, they're making it for their child, say, nope, don't want to know. And then some of the other issues are hope, uncertainty, the whole issues of surrogate decision making and what the roles of putting those kinds of burdens. Are parents in a position to take those kinds of burdens of making a decision for their child when their decision is 100% death, 95% death with greater suffering in the interim? Those are pretty crap decisions. The consequentialism, I say that in that feminist ethics and palliative medicine, we look at the process as well as the outcome. And so people who tend to look only at the outcome, 5% is better than 0%, versus if you're somebody who looks at the process, you've got that. And then the multiple interests, I described that all of these entities, child, parent, NPs, researchers, institution, funding, reputation, and future children are potential stakeholders in there. So my thinking on this is that it's all framed by uncertainty. In fact, I have this slide in here 2 or 3 times because you don't know, are the harms predictable? Well, you have some statistics, but when you're the child, it doesn't matter what the statistic is, your N is 1, it's you. Are the harms unpredictable? And also, do the harms have some inequity? Do they vary by other vulnerabilities? And how do we think about that? How do we express that? So this idea is going to come up a couple of times. So one of my purposes in doing this talk was to think about how to, I think it's a continuum, using those ethical frameworks that are right in the middle, in the considering multiple ethical frameworks, and that by that I mean the feminist, the principalist, narrative, virtue ethics, and looking at where a particular scenario of my 3 stories fits on here, and factors that might indicate that it's unacceptable or dubious at best, and factors that might look at it being beneficial. All right, that was an introduction story, actually. So we'll gonna go to story number 2, but keeping story number 1 in mind. And actually, so in the framework here, the 3 stories, I'm gonna spend the most time actually on story number 2 here, and story number 3 is just gonna be pretty small. So if you're watching the clock, you'll have an idea of the time I'm spending. So story number 2, I call Consent Steroids, Social Workers and Young Men with Duchenne's Muscular Dystrophy. And I'm going to explain what Duchenne's muscular dystrophy is because it's relevant. So there's going to be 2 slides on that. But this is what happened when the research team moved the psychosocial support team out of the clinic, because there was a real estate constraint in the clinic for both time and rooms to have both a major research team and the social workers and counselors and other people who had been there when it was just a little supportive children's hospital. When they're providing lifelong but disfiguring treatment for these adolescent and pre-adolescent children. And I was thinking the 3 things to listen for in the story are why now? Why is this an issue in this part of time? Second, the interest of the child in front versus the child in front of the team versus future, and again, informed consent. Okay, so this story starts that the palliative care team had been there for a while, but there was a whole turnover of people in the Duchenne, the DMD is Duchenne muscular dystrophy clinic. We had one older researcher who was an amazing international figure in curing muscular dystrophy. And we had a younger one who had just come to our institution. And it was the younger one who came to us and said, hey, palliative care team, we want to learn from you. We're seeing a spike in psychiatric presentations of our young men in their adolescent years with Duchenne's muscular dystrophy. And he describes that they included things like suicidal ideation, suicide attempts, and harming others. Some of those harms were running them over with their motorized wheelchairs. And they'd had 9 emergency referrals to psychiatry a short period of time, and the psychiatry service couldn't even take them because it was underfunded. So he wanted to explore why now, what was going on, and what we could do. And it was actually not me, but all of the rest of the team, particularly the psychosocial support team that worked in palliative medicine, who got very involved with this. All right, so I'm going to go back. What's Duchenne's muscular dystrophy? It's X-linked. It affects boys. It's pretty common. It results from a deficiency of one protein, and it makes muscle weakness. That muscle weakness starts in childhood, but a lot of these boys lose the ability to walk. It used to be in mid-childhood. Now it's in late adolescence because of the different interventions. I'm going to describe one of the interventions. They have normal intellectual development, and they lose their independence just at the stage where they usually separate from their parents. They also have normal sexual function. And that what are the concerns of adolescent boys? Are they the same concerns? They have a premature death that used to be life expectancy was before the early 20s, and now we're into the 21 to 40 with a median of around 30 if they're using like a CPAP mask at night. All right, so that's our context. Why? Well, I'm going to answer the why now thing is that there's super exciting treatments that were on the horizon when I was at this institution and are pretty much now here. That you don't have to know anything here. This is just a picture of there's new drugs, there's genetic therapies, and when the children are diagnosed and treated early, they can prevent the weakness that went on to death. Does not work though in preventing, and once the harm's been done, it's done. So my psychosocial team went down and talked with them, and the palliative care nurse practitioner had worked in a Duchenne's muscular dystrophy clinic for years. And what she noticed is that when her career had started, boys in high school, they appeared normal and they were in wheelchairs. And she described wheelchairs as chick magnets, that the girls wanted to come and hang out and talk with these boys. And for reasons I'm about to explain, that with the life prolonging treatments, the adolescents were entering high school, still walking, but looking extremely awkward. And that they had they were disfigured, a lot of them, not all, from the treatment. And the treatment in particular is steroids. And I'm going to show you. So this is the range this is in Duchenne's muscular dystrophy, receiving daily steroid treatment. That this is uncommon, but this is also only modestly common. Usually their face gets fuller. This is the extreme of how disfiguring steroids can be. And this is what the Muscular Dystrophy Association says about steroids, about why. They said it's effective in slowing the course, that children should be started on these before their decline. It's significant increase of strength, 11% versus placebo. There's some evidence that it improves survival, with 3 studies saying yes, a 4th study saying not sure. And then they say about the side effects: weight gain, short stature, acne, behavioral changes, osteoporosis, long bone and vertebral compression fractures. So my summary of my story is that steroid treatment is recommended for all boys to prolong life. The dose had gone up substantially in the previous few years before this, our moment when these suicidal ideations were happening. And that the use of steroids straddles research, innovation, and standard treatment. It's some of each. Duchenne's muscular dystrophy used words like should be started at diagnosis. It's deforming and socially altering treatment. And there's supposed to be an interdisciplinary team involved for all of these. If you read the literature, this says that this should happen for all of these reasons of how to manage transition to adolescence and sex ed and everything else. So here's my 2 problems with this. One is that the focus on research in our clinics meant that the psychosocial teams weren't available because the researchers were occupying that time and space. The child and families lost routine access to their support teams. They had increased medication side effects with social consequence at the same time as this reduced support. And their increased distress started showing. Further, we were not sure exactly what informed consent consisted of. with the recommendations from the Duchenne's Muscular Dystrophy Association, start steroids as soon as you're diagnosed. We don't think that there was ever consent happening, just by guessing, not for sure, about saying that your cute 4-year-old right now who's just been diagnosed with Duchenne's, if we treat them there, they'll be walking longer, they'll live longer, but they're going to be miserable. They might be miserable in high school because they have been disfigured by their treatments, and their peers can be cruel to them. So the why now? The cure is almost here. I think that it gave parents an increased sense of urgency and an increased sense of hope for the benefit of their child. The research that these parents were involved with, although it was not likely to help their child significantly and extend their life, it might, and it certainly would help the next generation. The providers had an amazing sense of urgency because these guys were curing muscular dystrophy. I mean, it's just amazing. But it shifts that balance slightly from this is the child in front of me to what's the greater goal of this cure. And then the problems with informed consent, including a potential, again, to get children to participate in that study. Maybe you don't want to emphasize that they could have terrible psychosocial problems in high school when you're talking about at age 4, 5, and 6 of prolonging their life and joining into the movement to cure Duchenne's. And then we also know, I have a lot of literature, the asterisk here is that parents overestimate the chance of cure for their child. When they participate in this research, they can be told over and over and again that it probably will not benefit their child. But if you take them aside and do a research study and ask them what they understand, what the purpose is, they will often conflate that it's going to help their child. Okay. So I've already said this, but this is the interests of this child versus future children. And I can appreciate, you can hear me appreciate curing muscular dystrophy. It would be an amazing thing. But my clinical focus was the child in front of you, and what was their life experience and how to get them through wherever we intervened with them and their death to make that as happy an experience for them as possible. The other interesting thing about Duchenne's is empower the child in their decision-making when old enough to assent and then consent. When the decisions are made about these steroids, they're not part of the decision-making. They're pre-adolescents. They're probably maybe even younger than 4. Certainly as they get into adolescence, they can make decisions, but by that time, a lot of these changes have already occurred. So the informed consent dilemmas, how do you weigh the quality of life versus the quantity of life? And how do you present this information to parents? Again, if the child is 4. Do you do it again at 6 and at 8 and at 10? Or do the parents get mad at you and say, stop it? We don't want to hear it anymore, we know. It's easy to measure longevity and the time ambulating. I didn't mention this, but that change from the kids entering high school in wheelchairs versus the kids entering high school walking. The longer people walk with Duchenne's, the better they do. It keeps their spine and their respiratory and everything else going. So it's a great early sign of how long that they're going to live. So you don't want to put a child who can walk into a wheelchair to go into high school when they're going into high school. And then the hope for their future is the big picture success grants and career advancements, particularly for the researchers. That's they don't talk about that, but it's got to be under there somewhere that you're going to be the guy who cured Duchenne's, or the woman who did. And then the tension is as the surrogate decision maker changes into the emerging decision maker, what happens when they disagree? Who gets to decide? So the adolescent, one of the things that when my team talked about this was we thought that the adolescents would probably have wanted more consideration to their social connections and to avoid bullying than their parents were worried about when these decisions were made. And I thought about the difficulty. I had developed an interest in intersex adults when these are people with differences in sexual differentiation who, once the internet came along, as adults, they could find each other and talk about that experience that isn't generally socially discussable outside of the internet and say, you know what, as a group, we think our parents screwed up. Our parents and the doctors screwed up, and really we should have been treated like this, and to advocate and form advocacy groups. And so part of me wondered if these young men with Duchenne's would they? That's a question. I don't think it's been studied that I know of. Would they want to tell their parents and future parents, hold back on the steroids a little bit. I'd rather live less long and have a really good experience in high school. So this is the biggest meat. I'm getting into, there's some really busy slides coming up here because there was a lot of ideas. This is sort of the peak coming up. So looking at these dilemmas, how do we approach them? I've already showed you this slide, but I'm about to apply it in a busy slide. Seen this slide before. Unacceptable, beneficial. All right, so now how do we weigh these? So I'm gonna make boxes, and my next slide's gonna have some of these boxes from, this is my summary of virtue, narrative, feminist, and principle-based ethics. And so in looking at the beneficial and encouraged spectrum, you've got minimal harm or long-term harms. Okay, great. We're right there with Nuremberg on there. We have a health and well-being benefit to the child, particularly if it's both immediate and long-term. Those are easy if they aren't in conflict. That everybody's well-informed, and like is treated as like, including the more vulnerable people. In my Duchenne's example, I think of those kids who enter high school who already have other vulnerabilities in their family or in their, perhaps a comorbid neuroatypical or, anything like that. And you take that and you make a child like that somewhat disfigured, and you have magnified their experience, their negative experience. Then feminists, the relationships and processes are healing and generally fulfilling no matter what the outcome. That the research promoted a sense of interdependence, community connection, sharing, and trust. That there was a sense of meaning to the child, even if they didn't get the desired outcome, and the same for the parents. And that the community too assigns a positive meaning to this story that they've given to the future. And the story will pass community scrutiny now and in the future. And then finally, virtue, that the providers and the researchers consider what does a good provider do, and that they're considering some of the vulnerabilities of parent and child and compensating for those. All right, this is second busy slide, looking at the opposite. Now, this is just principle-based ethics. I had to pull out virtue and feminist ethics and narrative into the next slide because it didn't fit, because these are busy slides. So the unacceptable or dubious at best, what features would make it lean towards that end of the spectrum? So certainly harm to the child, especially immediate and severe, or long-term harm that's especially if severe. No benefit to the child, harm to the parent or a vulnerable surrogate decision maker. Now, as I'm going this way, these are more harmful, less harmful. So if there's harm to the child, but it's not severe, and it includes a psychosocial harm versus a medical harm, perhaps that I'm going to say that that's worse than if your child, even if they had psychosocial harm, than if they had died immediately. But when you talk long-term harms, it should include all types of harm, including psychosocial. And then, so we've got the autonomy ones that parents, the worst would be if the parents were deceived. And then on the better end is that if there was unaddressed, unrealistic, or false hope that the innovations would allow the child to regain lost function or life expectancy. Right, and then we've got justice and fairness where you've got issues of a vulnerable child or parent would be more likely to experience harms or more or less likely to participate in the research. Going on to the feminist narrative and virtue ethics in one slide. So the psychosocial and the feminist is psychosocial, that the research interfered with their sense of interdependence, community connection, sharing, or trust, and that the research and processes are difficult, cause conflict, or generally unfulfilling, no matter the medical outcome. We've got virtue that the providers aren't considering acting. They're acting, my little concerns that some providers have incentives to prioritize the research because that's their career. And that, the meaning, this is the opposite side of the same story of what we talked about, that do they have meaning? And are they vulnerable or not? That's the last of the busy slides. So before I go on to the final story, my last thoughts about informed consent for the innovative treatments. The research treatments, will they help my child? And what are the uncertainties? I don't know how they approach disclosing differences in susceptibility to negative treatments, children who have other vulnerabilities that are known. How does that impact? I don't see many research protocols having that in there and saying, if this child has, say, coexisting neurodiversity, and then that's known of at age 4 when they start steroids, how is this going to affect their ADHD and their... I think that material that shows effects, things like photographs, videos, and testimonials, most research consent processes are very based on written words. And I think that that's a big limitation. I'm hoping that that is going to improve with time as we have more videos, photographs, and testimonials. But I think that the photographs of the kids with Duchenne, of the steroids, those are, I don't think parents are shown those photographs. And I think that those are pretty confronting. And then what age of, who and when considers it at what age? How often is it revisited? And we're back to uncertainty. Told you I'd get there again because it's just always there. So the last one's going to be shorter, though it does require some explanation about what the disease is. And I call this the heartbreak story. So there's something called hypoplastic left heart syndrome. The briefest version is it's bad. The story is what happened when adult congenital heart specialists joined the pediatric clinical team and found these young adults. They go in to see these young adults, and these young adults think that they were cured of their congenital heart disease with the surgery that they had when they were a baby that they don't even remember. And the palliative care team was asked to become involved with, we call it the HLH, hypoplastic left heart, and it's also called single ventricle physiology. Sorry for so many terms, but I'm going to use hypoplastic left heart. And the reason why these adult specialists had showed up in the pediatric hospital is a really good reason. It's because in general, congenital heart disease patients are doing really well. But these were the most challenging patients. And I'm going to tell you why. I'm going to do this fast. The heart has only one ventricle instead of two. It used to be 100% fatal in early infancy. In the 70s, they developed a procedure with the surgeries. The children has a 50 to 60% of survival to age 1 year. After that, they do really well throughout childhood. The ones who've done really well, some are left with serious permanent disability from the surgery. The surgical team The surgery has improved too as it goes on. So the ones that were done in the 70s, the 80s are going to be better, the 90s are going to be better. But they found that right now, these young people in their mid-20s are developing serious complications. I'll show you a picture of them. Serious complications, and that most of them are dying in by their early 40s unless they have a heart transplant. So those are the organs that are affected. It's complicated, but it's bad. And they're getting better at this, of course, as we go on. This story is now about 10 years old. But the children had gone through their adolescence. Everybody had seen such wonderful results once the kids got through the early stages that they considered it practically a cure. And these young adults didn't know the name of their condition. They thought they were cured, and none of these patients that these now adult cardiologists are seeing knows that none of the children, the former children, know they have a life-limiting, life-threatening condition, and that the women are going to have a hard time with pregnancy. They could die from trying to have children, and they don't even know this. So these adult cardiologists were finding that they had to disclose this information to these young adults, and it destroyed the relationship between them. My pediatric cardiologist, we never talked about this. I didn't know this. You can imagine it was just extremely confronting. The young adults were sad, scared, angry, existential threats, a sense of betrayal. They want their new doctor to be as optimistic as their old doctor. And their old doctor was optimistic. There was good reasons. I mean, there was a 30-year lag, 40-year lag before we knew that they were all going to die in their 40s. And the young adults found it difficult to form a trust relationship with these new providers. So one of the things that's going on in this field when I was in it is that there was a question. Some of the pediatric cardiologists were saying that the parents of babies who are diagnosed with this should not be given the option to say, no, thanks, don't want surgery, given that there's a 100% death rate if they say, no, thank you. There's a 50% death rate, approximately, a little less, if they say yes. But then there's these 40-year later sequela of these young people dying. And so we're not going to go through all of these, but the same set of criteria that I just used for the muscular dystrophy, as well as the uncertainty. I mean, we might get better. The chances are we'll get better at this over 40 years by the time these children the parents are making the decisions now. But how do we decide, trying to use ethical frameworks, what the right thing is to help guide parents and the healthcare providers who, of course, we're so close to curing such a horrible disease as one ventricle physiology. And the providers, I think, are incentivized to give it a go, because it'll help the next generation. So I'm finishing up. I'm going to start with questions, but I just said our companions on this journey were uncertainty. I love these narratives. I've given them a lot of thought. I think the stories are important. And then the different types of ethics. And thinking about suffering and meaning. And what does it mean for everybody involved? I think I had suffering and meaning, and I was on the periphery of these stories. So, the people in the center had quite the time and to appreciate that. All right, so that's
Questions? All right, thanks, Janine. We'll just turn the camera around. Oh,
Got people online.
Yeah, bring it in.
questions?
I'll let you.
Grant.
I always think that although it's been totally incongruous in the context of feminist ethics, one can't go past the Dirty Harry principle.
Yeah.
And the Dirty Harry principle is a man's got to know his limitations. Now, I think as soon as you try to convey that to patients, we can do this. I guess there's a faint chance that something might show up in the future, but at some stage we're going to have to have a serious discussion about the limitation. Now, when would you like me to do that?
Mm,
How would you like us to proceed?
mhm.
Because I don't want to create false hope, and I don't want to impart false promises, and I don't want you to get caught up in a whole process of medical chutzpah into making what is really a silly decision.
It's definitely true. It's so hard about when and how much time you have for those. I think the Duchenne's you have years for those, but certainly with deciding how to proceed with a child who has a heart defect that if you don't fix it now, they're gonna die, or a bone marrow transplant area, if you don't, you have, days to maybe weeks to decide. Yeah.
Other questions? Oh, someone,
They might not be able to ask them. I was muted last time.
if you've got a question online, you can just put your hand up, either using the little icon or in real life.
I'll ask a question. Thanks, Janine. It's obviously, things that have been very personal to you, and it's really helpful for us, I think, to hear these examples and the questions that they're wrestling with. I have some thoughts about, or just maybe it's a question, maybe it's a thought about the relationship between the theories and the way you're trying to process these issues. So I didn't quite pick up what's going on as you had those spectrums, and you're seeing things in the different theoretical approaches that seem to be useful, I think. I probably need more conversation to understand that exactly. But on the subject of informed consent, so the journal article you cited, I think it was titled "Is Informed Consent Possible?" And that tenor, that could be the question that one would take from this. And then a further implication that one might draw is that, there's some problem with informed consent. I would suggest that it's because we take informed consent seriously that we find these kinds of problems. So we're thinking, like, what does it mean to adequately inform someone? What do we owe to people in making these decisions? So it's not, I would just say these are the kinds of cases that really show how difficult informed consent can be, but it's not a reason to abandon the presumptions around informed consent that we have. So
Yeah, I completely agree with that the informed consent has to be part of these processes. I think the way that I see this, we used to give talks called sharing the moral burden.
Yeah.
Which is that in the US where these cases were, that it was a bit more of, well, I don't think this is the right approach, but the parents want it, so we're going to do it. And these are the senior clinicians saying this.
yeah.
And I think that I see that less in New Zealand, and I think that, again, the first case, the bone marrow transplant, it's an impossible decision. And so therefore, I think that the clinicians need to weigh in more about saying that when they identify things are more likely to cause suffering for that period of time, and less likely to guide parents and not just say, well, here's the facts, go at it,
It's interesting that I think you're absolutely right, and this comes up in lots of ways, but it actually shows that informed consent is a check on autonomy in a certain kind of way. Yeah. Or at least a kind of pretty narrow view of the problem.
John?
So I was thinking about one of Dominic Wilkinson's points in his book on neonatology ethics and decision making. He talks about the Carmentis machine, which is a machine which can tell you exactly what's going to happen in the future to this child. I was thinking about uncertainty in those three cases. It seemed to me that in the last two, there was uncertainty, but it might not be the thing that's really turning some knots, but with the bone marrow case, maybe it is. So I was kind of thinking about uncertainty applies in different ways, in different contexts, and in those three cases.
Yeah, uncertainty in children, it seems much more pronounced even than uncertainty in adult medicine, having done both. It's so difficult to predict any particular child what's going to happen, and so you make a dire prediction and a child does really well, or you say the opposite. And I came to appreciate that, and I came to very much use it in all of my language with families, much more, I think, than I had at the beginning of my career or with my colleagues did, is to acknowledge that uncertainty, to stress that, honestly. Makes it hard.
Grant.
You have to think that, because a very striking experience I once had was a kid who came into the hospice in Oxford. And I discussed this with one of the hospice doctors. And the kid said he'd come in for the weekend and he'd sent his parents off to France to have a holiday. So everybody thought, oh, well, this is a good idea. Everybody gets a break. And after he saw them drive away, he got hold of the specialist and he said, this weekend, we're going to have a proper honest talk. You're not going to tell me all the nice stuff. You tell me when my parents are here. So come on, I'm going to get it straight, because I know that I'm going to die and they don't want you to tell me.
Yep. Yeah. And that the Duchenne's example certainly is that transfer of parental to and it would normally be a full transfer, of course, but with the children with Duchenne's, they never get to full because they become physically dependent on their parents, and it's really difficult. Then they have to do things like you just described to get their parents out of the room to have a conversation, because their parents are caring for their physical needs.
Thank you, Janine.
All right,
We are up
thanks.
to time. Next week, Grant is giving a talk, so we'll all see you back there.
Yeah.
Any questions online first? No? All right, let's show Janine our appreciation.
Thanks, Janine. Great cases.